Hello, friends and colleagues, and welcome to episode 109 of Dermasphere, the podcast by dermatologists, for dermatologists, and for the dermatologically curious. I am one of your hosts. My name is Luke Johnson. I am a pediatric dermatologist and a general dermatologist with the University of Utah. And joining me, of course, is...
This is Michelle Tarbox. I'm an associate professor of dermatology and dermatopathology at Texas Tech University Health Sciences Center in beautiful sunny Lubbock, Texas.
And the third unofficial member of our group is the Pimping Bell. Say hello, Pimping Bell. Pimping in the world of medicine refers to asking questions of your learners to try to elicit information and improve their knowledge. So when the pimping bell rings, it means we're talking about something that's especially question-worthy. So pay attention. So I'm going to talk about botulinum toxin injections as an effective treatment for patients with intertriginous Hailey Hailey or Darrier disease, an open-label 6-month pilot interventional study. This is out of a journal called Orphanet Journal of Rare Diseases. The authors include Isabelle Dreyfus and Juliette, I'm going to mispronounce it, Mazirou-Hautier out of France. So first of all, shout out to Dr. Lindsay Wilson, a local dermatologist here who clued me into this one. So Hailey Hailey disease and Darrier's disease. Usually you see these in adults, but they're still genoderm. So, we pediatric dermatologists love our genoderms. They're pretty uncommon. I've probably had 3 or 4 patients total who've had either of these diseases. Michelle, how often do you see these down in Texas?
We see some, I would say at least a couple cases a year.
Well, they're often spoken of in the same breath because they're both caused by mutations in calcium channel proteins. Pimping Bell, are you paying attention? So the mutations in Hailey Hailey are ATP2C1, and in Darrier's disease, ATP2A2.
I have a silly way I remember this.
Please.
Okay, so Hailey Hailey is not rare but not terribly common, but I guarantee to my derm residents that while they're in dermatology residency, they're going to get 2C1. They're going to get 2C1 in their dermatology residency. And I always thought that Darrier's sounded a little bit like Cockney, so I'd hate to have Darrier's. So it's like A2,
I love it. Well, they can both present with primarily intertriginous findings. So intertriginous is the major skin folds, including eroded plaques, bad smell, which we call malodor, pain, susceptibility to infection, and can, as you might guess, have a significant impact on quality of life. Botulinum toxin. I'm going to just call it Botox. Nobody's sponsoring us. There's a lot of different botulinum toxin injections out there, but Botox has been reported in a few patients to be helpful, and this is a larger case series kind of looking at it. This was an open-label trial in 30 adult patients. 26 had Hailey Hailey disease, 4 had Darrier's disease, and they got botulinum toxin A, actual Botox in this case, diluted to 2.5 units per 0.1 ml, which is usually the strength I use when I treat hyperhidrosis, but I think usually when we're using it cosmetically, it's 4 units per 0.1 ml. Michelle, you use way more than I do on your patients. Do you feel like that's correct?
So the package dilution is 4 units per 0.1 ml. I like when I'm doing it for hyperhidrosis, especially if I'm doing it for a bilateral process, to hydrate a 100-unit vial with 5 milliliters, because then that gives you 5 mLs. And I divide those up into 2.5, basically, syringes per side. For most indications for hyperhidrosis, that results in a satisfactory distribution of product unless your patient is very large or has a high severity of sweating.
So then you're doing 3.5 units per 0.1 ml or something? It's less than 4, but not as low as 2.5?
Well, so usually we are suspending the 100-unit vial with 2.5 milliliters of bacteriostatic saline. So that gives us the 0.1 per. Does that make sense?
Normally, if you got 100 units, you put in 2.5 mLs of saline, and that's how you get to 4 units per 0.1 ml. So you're putting in twice as much.
Yes.
So I guess you get
2 units per 0.1
2
ml.
units. Okay, so it's about the same.
Yeah.
And so they used up to 200 units per patient. And just like how I do hyperhidrosis, these patients were injected in a grid, so about
Hmm.
1 to 2 centimeters apart with each little dermal injection. It sounds very similar to treating hyperhidrosis. And the affected area, most of them were in the axilli. For pain control, they had them put on EMLA about 30 minutes ahead of time. So people did get better, often within
Hmm.
the first month. Both
Yeah.
symptoms and quality of life improved. There was quite the range of improvement, anywhere from 24 to 93%. And these improvements generally persisted even at a 6 month follow up after a single session. That's pretty good. However, 37% of the Hailey Hailey patients relapsed during the 6 months observation period, even though they initially responded well.
Hmm.
The
And what's
authors point
interesting
out that
is,
these. Go ahead.
I was going to say, what's interesting is you'll see persistence or recurrence of the disease around the treatment area. So you can kind of see where the treatment is working. And then right around the periphery, it's almost like a negative space thing of where the disease activity comes back.
So you've done this procedure
Oh,
on some
yeah.
of these patients.
I have a kind of family of Hailey Hailey patients that's in this area, so we have a pretty good cohort. I misspoke earlier. I forgot about the like group of patients that we're treating with the Botox. But the cool thing about the Botox treatments is that the patients tend to also have kind of discomfort improvement. So like a lot of patients suffer from pain with Hailey Hailey, and what was interesting to me was that the pain got better faster than the skin disease got better, but it kind of makes sense because there's a local effect of Botox on inflammatory processes, especially like mast cell signaling and things like that. So that was kind of interesting to me, kind of from a pathophysiologic standpoint.
So you have a group of patients who are already doing well on this treatment.
Hmm.
That's great. So these patients in their study who relapsed, they point out these were the most severely affected patients, and they wonder if maybe the relapse was because they were required to stop other therapies before enrolling in this study. Also, since they were the most severe, maybe they would have responded to higher doses of Botox or perhaps more frequent injections. 27% of patients reported a significant discharge of clear fluid from the area after treatment that persisted for a month. Have your patients talked about that?
I don't know if they're just so happy to get the treatment that they don't complain about things, but I have not had that complaint. I wonder if that's the saline kind of leaking back out through the sort of improperly covered skin, like that, or the skin has a incomplete barrier. So I wonder if it's that. That's an interesting question.
Authors weren't quite sure either, and
Hmm.
interestingly, this clear fluid discharge is described in their paper both as mild, doesn't sound so bad, and also as debilitating.
Hmm.
That sounds pretty bad. I suppose perhaps you can have something that's mild, but it still prevents you from doing the things you want to do, so it could be considered debilitating. Overall, 70% of patients were satisfied or very satisfied. It's not so bad. Also, Botox injections are pretty safe. They point out that sweating probably worsens a lot of the symptoms in these patients, so that could be one reason why Botox is helpful. However, many patients experienced a return of sweating and malodor after the first month, but their overall efficacy was still good. So maybe it's like you say, it can impact some of the inflammatory molecules or some of the neurons or something. Limitations, of course, there was no control group, and natural disease fluctuations are significant, so perhaps these patients enrolled just when they were really bad and they naturally weren't so bad by the end. The old regression to the mean phenomenon. They point out that surgical ablation may still be the right option in a lot of patients because it can potentially be more permanent and can treat a large area. Have you used that with like CO2 laser or something in any of your patients?
Yes, we've tried the CO2 laser for a couple of different patients, and one patient that actually has an epidermal nevus with Derriers in it. And the
Oh.
epidermal nevus patient did the best, which doesn't super duper surprise me because the density of the mutated cells for that patient is smaller, and she has more normal cells kind of surrounding it. Whereas the patients with Derriers, the whole skin surface has it, and it's just the intertriginous areas that have the um, deleterious effects because of friction. But the cool thing about it is that if you do that with the like Botox therapy, like if you do the Botox, I like to like let the Botox be present for at least a couple of days before I do something resurfacing, just so that I don't have the possibility that edema fluid will wash the Botox into areas I didn't intend for it to go. In the axilla, you think about like the brachial plexus and making sure you're not going to cause like like a nerve dysfunction or muscle weakness or anything like that. But I found that the patients that had the Botox treatment and then the CO2 actually healed faster. which is kind of
And the
cool.
brachial plexus thing, you maybe worry about that a little bit with lasers or with Botox or both, or
Oh,
not really either.
um, not with lasers. I don't think you're getting anywhere close to deep enough with that. High doses of Botox in the axilla for some patients have correlated with weakness, but most of the time when you have weakness related to Botox for hyperhidrosis, it's in the hands, and it's usually with higher dose.
Yeah, the brachial plexus is way down there
It's deep.
that I
It's
guess
deep, and
Botox can diffuse.
well, it's a theoretical concern. Just makes me cautious to honestly. It's probably overkill, but like for example, I would not do CO2 resurfacing on a person's face on the same day that I would do Botox, because if you've ever done CO2 on somebody's face, they swell up like a kind of puffer fish usually the next day, and all that edema fluid might move things around where you didn't intend for them to go. So it's
A
probably
few
more
other
just
little.
dogma.
Sorry, say again.
It's probably just me following dogma there, but it makes me feel better to wait a couple of days.
That makes sense. So, a couple other notes. Botox has also been helpful in pachyonychia congenita, if you have any of those patients. Botox, of course, works by blocking the release of acetylcholine, which we know stimulates eccrine sweat glands. And based on data from other disorders like spasticity, max Botox per session is about 1,000 units,
Hmm.
or 30 units per kilogram, whichever is lower. The authors of this study had no conflicts of interest. That's all we got for today, guys. So you're probably hanging on the edge of your seat about menopause and derm. We'll make sure we hit that one next time. And thanks for joining us today. Thanks, of course, to our institutions. Thank you to the University of Utah for supporting the podcast, and thanks to Texas Tech for lending us Michelle. Thanks very much to all of our members of Team Dermasphere who keep many aspects of this podcast moving along. Yes, thank you to Morgan Dykman, Guy Kusecki, Eleonora Marcacci, Michael Birdsall, Aparna Nayak, Neha Deo, Haley Walsh, Angie Wong, and Lara Dela Cruz. You guys do a lot for us. One thing you do is keep our social media accounts moving along. You can find us on Facebook, Instagram, and Twitter. You can also find us on our website, dermaspherepodcast.com, which has links to all of our original articles as well as our entire archive available for free. As a reminder, please come out and hang out with us at the University of Utah Dermatology Echo virtually, one Friday out of every month. And also come see me in Idaho and hang out and learn some dermatology, a couple meetings there in September. And you can find some of our content on video through the View Medi platform. Also, I wanted to let you guys know that I'm going to be at the Society for Pediatric Dermatology meeting in mid-July. So if you happen to be there around July 14th or 15th in Asheville, North Carolina, come say hello. Michelle is going to be at the World Congress of Dermatology. It's possible you'll actually already have returned by the time this airs. But if not, if you're hanging out in Singapore, say hi to Michelle.
Woo!
Michelle, play us out with your Snoop Dogg reference.
Oh no! you you want me to just do 1, 2, 3 into the phone? Snoop Doggy Dogg and Dr. Dre is at the
Well,
top.
last time I think you said, and just chill till the
Until the
next
next
episode.
episode. No, oh my god, I would have gotten there eventually, but it would have taken me the whole song. My apologies. So
Okay, one more
just chill.
chance.
Okay, so just chill till the next episode. Do, 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 do.